Welcome back to the Valley Wellness Podcast. I'm Dr. Tennille Cloward. I am here with Taelor Lewis, and we have a very interesting topic today, something that is very important, very common.
Very misunderstood.
Yes. Dive right in.
Yeah.
We're talking about PCOS, which has a very misleading name.
Yes, it does.
Tell me why, Taelor.
So PCOS stands for polycystic ovarian syndrome. In the medical community, it has been discussed about changing this name because it is very misleading. Polycystic ovarian syndrome, when I say that to patients, hey, I think this might be what's going on. Well, I don't have cysts on my ovaries. You're right, you don't. Cysts on your ovaries are just a component of PCOS. It's not the whole picture, which is why, like I said, it is misleading. Often a symptom of PCOS is anovulation. So when you're not ovulating, you're not having cycles, and under an ultrasound, that will look like small cysts on the ovaries because they don't mature fully. The ovaries don't release an egg. So that's where PCOS and the name came from.
Given this terrible name.
Yeah. But it is PCOS is a syndrome. And in the medical community, we call things syndromes that have, kind of a myriad of symptoms, and we kind of package them together nicely so that we can understand and explain them a little bit better.
Right. What are some of those symptoms that a woman might have? What might she present with when she comes to see you?
Common symptoms include those irregular periods or just not having periods at all. Some other things that we might see are symptoms like hirsutism, which is unwanted hair growth, coarse hair usually on the face, the chest, sometimes the back, sometimes hair thinning.
You lose hair in the places you
Yes.
want it, and you get hair in the places you don't.
Absolutely. Yeah. Very not fun for a woman for sure. So male pattern baldness is that hair thinning. Acne, unfortunately, sometimes real struggles losing weight, and we see obesity and things like that. Other things are, psychological, depression, body dysmorphia, anxiety. You can have sleep disturbances with PCOS, insomnia, trouble falling or staying asleep, significant fatigue. It goes on and on, but those are probably the biggest ones I see in practice.
See. So what happens when you have a patient come in and she says, my mom has PCOS, my sister has PCOS, I'm sure I have PCOS. How do you counsel them about the possible heritability of something like PCOS?
Yeah. So, prior to just recently, we really didn't know what caused PCOS. We would, maybe it's genetics. If you have that strong of a family history, maybe it's the environment or your lifestyle, work harder to try and correct this. But a really interesting study came out in 2019 that looked at over 10,000 women's genes that had PCOS to see, okay, is there a genetic component to this? And we found that, there is not one PCOS gene, right? It's not this, oh, dang it, you are doomed for life. You've got the PCOS gene. But there's actually hundreds of genes that can predispose someone to having those underlying conditions that do cause PCOS. And you may have a few of those. You may have a lot of those. You may have, just some of those. But they're epigenetics that are then either turned up or turned down based on the environment that you expose them to. And we're talking about the environment from in the womb to childhood, adolescence, teen, adulthood, and whether or not the symptoms of PCOS then are presented because of these underlying conditions. And these genes include things like how our body utilizes insulin, hormone regulation, metabolic health, how our body handles stress, how our body handles inflammation or what it might, the foods it might respond to, and et cetera. So I like this description of PCOS or this cause of PCOS,
right,
because I think it gives women with PCOS a lot of hope because unlike the genes like our hair color, our eye color, our skin color, those are black and white, they're set in stone. Whereas these genes can be modifiable.
right.
And I think that's, I often get asked, can I cure PCOS? Will this ever go away? And I do think we can make changes to dampen the susceptibility that these genes have to creating these symptoms of PCOS.
Right. There's no cure for PCOS, but it can be well managed.
Absolutely.
And it's good for patients to know that having a strong family history of PCOS does not mean that you have to suffer with all of those symptoms, that there are management strategies that can help manage it to where you don't have symptoms.
Absolutely.
If you're doing all that you can.
Yeah, absolutely.
But taking a step back, you have the patient come in to see you and she says, either my mom, my sister, they have PCOS. Do I have PCOS? Or she comes in and she says, I have symptom X, Y, and Z. I've got this acne. I'm not having regular periods. What are the next steps to help diagnose PCOS?
Yeah. So first of all, information is super important. And I think one of the reasons why it's really hard to diagnose PCOS is because often we normalize a lot of these PCOS symptoms. Sadly. Yeah. I mean, women often think, well, it's just normal to skip periods. Like, it's just normal. Oh, I've never had regular cycles. What are you talking about? Why should I bleed? I mean, why should I bleed every single month? And so, and oftentimes as a clinician too, we've believed that there's a stereotype and a box that we need to put women in for PCOS. They need to look a certain way. They need to have certain symptoms in order for us to say, okay, we'll adequately test you for PCOS. So I think, in fact, in my practice, I'm seeing more of the non-typical. They're not obese. They don't have severe acne. And yet when we do the right kind of testing, oh, wow, you've got a significant PCOS situation.
A fun fact is I've never been overweight. I've always had a very healthy lifestyle with regular exercise. But as a young girl, I had PCOS.
Yeah.
And I'm like, I don't look like the PCOS
Absolutely.
girl.
Yeah.
But, I never had regular menstrual cycles. We had infertility for years and years. And as I was able to get pregnant. I've got 5 children, but we had to use some of the tools that hopefully we'll get to today on helping those women who do want to get pregnant, who have PCOS. But as I learned to manage my PCOS, the periods returned.
Oh,
that unexpected
absolutely.
Pregnancy when my twins were only a year old. So
worked a little too well for you.
Right. But back then when I was diagnosed, I mean, this was, 30 years ago. Like,
when you were 12?
I didn't feel like when I was 12. But I didn't feel like I fit that picture. I didn't fit in this box.
Yeah. So I think that's a big part of diagnosis. So when I was taught in school, and correct me if I'm wrong on what you were taught, we were taught what's called the Rotterdam criteria.
Right.
And that included 3 things. The first one is ovulatory dysfunction, so irregular cycles or amenorrhea, just not having periods at all. The second was hyperandrogenism. So that's either with symptoms of that hirsutism, acne, or biochemical. We're looking at labs and seeing if you have high male type hormones, which are androgens and DHEA. And then the third one is cysts on your ovaries. And basically, if you had 2 of 3 of those things, okay, you have PCOS, let's treat you with ABCDE. I just think that's way too narrow of a picture for PCOS. I mean, we haven't even, it doesn't even discuss metabolic dysfunction, which we're going to talk really in depth about as a driver of PCOS. So when I'm diagnosing someone with PCOS, I'm looking at a lot of other factors. I'm looking at their metabolic health. I'm looking at their symptoms. We're looking at labs. I'm looking at estrogen dominance or progesterone deficiencies, because a woman can have regular cycles and still have a lot of underlying issues with that's associated with PCOS.
And what I think is really sad is I feel like some practitioners don't know PCOS as well as others.
Sure.
And so even if they have a patient who's got all of these just flashing light symptoms, they don't know the appropriate workup. And so they'll do kind of some of the more common labs and then say, oh, your labs are fine.
Yeah.
And then just dismiss them without being able to really take a decent amount of time to really dive into all of the important factors,
For sure.
as you're mentioning.
Yeah.
I had a friend's daughter just this week reach out to me who went in and saw a nurse practitioner in women's health, and she texted me and she says, well, she says my labs are normal, but yet all of her symptoms are still there.
Yeah.
It's important to realize that they're really there's quite a lot of things that need to be considered when we're diagnosing PCOS.
And to these practitioners' credit, like, normal is not optimal. I will often say normals are for sick people. I'm looking at optimal labs when it comes to the criteria that I go off of.
Yeah. What labs? Just give me a few labs that you would check.
So for sure. So initially, I'm going to check a fasting insulin. That is probably my number one lab that I'll check in these patients because we're going to, again, talk about this further, but when you're fasting, you really shouldn't have a lot of insulin on board. Insulin is a hormone that is used in the presence of glucose to utilize glucose for energy. When you're fasting, and fasting, 8-12 hours, you really shouldn't have a lot of insulin present. So if you have insulin present, it's very indicative of insulin resistance, metabolic dysfunction, that then wreaks havoc on a lot of other functions of the body. The other thing I'm going to look at is a hemoglobin A1C. So that is looking at your blood sugar regulation over the last 3 months. Women with PCOS are 3 to 5 times more likely to have and to develop type 2 diabetes than someone who's not, because insulin resistance is so prevalent in PCOS. So I'm checking those things. I'm also checking what's called a C-peptide, which is telling me how hard the pancreas is working to produce that insulin. And then I am checking for those androgen hormones. So I'm looking at testosterone, I'm looking at DHEA, and then I will look at estrogen and progesterone as well. Now, just to say, I don't put all my emphasis on estrogen and progesterone, because in a cycling woman or a non-cycling woman in PCOS, those hormones are moving targets. They're changing all of the time. So they do need to be checked at a specific time of your cycle. And again, if you're not cycling, how do we know if we've looked at that window?
Are you? Right.
So, I do check them. They can be helpful information, but I don't put all the stock in that. Another thing I will check is an LH and an FSH. Those are hormones that the brain signal to the ovaries to mature a follicle, to release an egg. And there can be a significant imbalance in those with PCOS also. So those are kind of my main labs.
When you keep saying this buzzword, insulin resistance, what is insulin resistance? What does it mean?
Yeah.
You want your body to be sensitive to insulin.
Absolutely.
Which means that the insulin is working for your body. What do you mean by insulin resistance, and why is this important in PCOS?
Yeah. So metabolic dysfunction really is a systemic disturbance in how our body produces insulin, utilizes glucose, and energy. So when I describe insulin resistance to patients, I describe it like this. So, we produce insulin through our pancreas in response to glucose. So we eat something, it can be the best glucose source. It could be an apple or whole grain bread, but that will raise our blood sugar, which then the pancreas secretes insulin. Insulin and glucose work together as a lock and key system, or a password system, if you will. Insulin goes in and grabs that glucose, pulls it into the cells, and uses it for energy. That is insulin sensitive. If you're insulin resistant, that password is sluggish, or it just doesn't work every time, or maybe the whole system is broken in and of itself. And that glucose then gets stored as fat, which is why oftentimes these women have a much harder time losing weight or maintaining a good BMI. And then insulin, when it's not utilized, it's a building hormone. And so it can then wreak havoc on other areas of the body. And in PCOS, it works directly on the ovaries. The ovaries create something called theca cells, which really rev up the production of androgen hormones, so that DHEA and that testosterone, which then cause the hormonal imbalances. So often when we look at PCOS, we see these symptoms at the top and we think, oh man, irregular periods, high androgens, we got to fix these symptoms with pharmaceuticals, which I do use in my practice often. But man, there is an underlying condition that we really need to work at.
What do you do? If you have a woman who has this insulin resistance, what are some ways that she can help her body become more insulin sensitive?
There are a lot of different ways, and we're going to talk about lifestyle and pharmaceuticals and things like that. But I want to talk just briefly kind of on the more mainstream treatment modalities, and then we can kind of build from there. So again, mainstream, we're usually treating symptoms. We're treating irregular periods with birth control. We're treating insulin resistance with metformin, which, again, I do use in my practice. We're treating the acne with a medication called spironolactone. We're treating infertility with an infertility specialist. Or, man, if periods are really heavy or irregular or painful, you're done having your babies, like, let's just take the whole uterus and be done, right? So, please don't get me wrong. These are amazing medications. They are incredible miracles of modern science, and I do use them on a regular basis. But if we're just treating the very tip of the pyramid and not getting to the underlying issue, we're not really correcting that hormone imbalance that's going on.
I feel like that is one way that practitioners will treat it. They send you out the door with a whole box full of medications, one to treat each individual symptom that you're having. And what ends up being missed is that counseling piece.
Absolutely.
That real dive into what are the main underlying conditions and reasons that you're suffering from the symptoms that you're having, so that the patient can then go home and make some lifestyle changes that might minimize the need for all of those medications.
Right. Well, and I think the big takeaway here too is PCOS is such an individualized syndrome.
Right.
You may have certain genes that are presenting these symptoms. Someone else might have the certain genes that are presenting these symptoms. It's so individualized, and it just really deserves an individualized approach to treatment. And we only know that through really adequate screening, laboratory testing, but also talking with our patients and seeing what their history has been and what their symptomology is.
Well, let's pick one of them then. Let's say you have a woman walk in and her biggest concern is that she's not having regular menstrual cycles. Whether that means she's not having them at all, has gone a year without, or say she's just having them every 45 to 60 days. What are you going to do to help her?
First, I think it's, again, important to realize what is happening and help explain to her what's happening when we're having irregular cycles or not having cycles whatsoever. And this can get a little bit complicated, but basically there's a hormone in the brain called the GnRH, and it is a metronome, if you will, for cycles. So it is supposed to work very routinely to send out signals to the ovaries to then mature and release an egg. In PCOS, GnRH is sped up. So it pulsates faster, and that causes an imbalance between the luteinizing hormone and the follicular stimulating hormone, to where you're not ovulating any longer. Those androgens have been increased, which then causes those symptoms that we talked about. But it makes it so that your body is not cycling on a regular basis. When you're not ovulating, you're not producing progesterone. And that is a huge component of period regulation too. Progesterone has a calming effect on that GnRH hormone, and it helps slow it down and bring it back into a good rhythm. So it's this vicious cycle that happens between low progesterone, high androgens, not ovulating, et cetera, et cetera. It's the leading cause of infertility is PCOS, because you're literally not ovulating. There's a lot we can do for infertility, but if you're not ovulating, it's not about timing. It's not about the partner. You have to ovulate in order to become pregnant.
Well, and sometimes these women will ovulate, but just not very often.
Right.
And so it's a lot harder to actually catch that
window,
rare ovulation,
right,
when you are trying to get pregnant.
Right.
But it is important for these women to know that having PCOS doesn't mean you can't get pregnant.
Absolutely. Absolutely. One of my favorite things when I'm treating someone with PCOS or when I'm helping a woman with infertility is when they come to me and they say, my period came back. I had a period this month. And it's so exciting. I mean, most people are not super excited about their periods, but when
these women are.
These women are super excited. And I love that for them because we are treating that underlying condition of, metabolic dysfunction that then lowers those androgens, that then helps make that gonadotropin hormone release on a more rhythmic schedule. They're ovulating, progesterone's rising, and we're fixing that underlying problem associated with the hormone imbalance that is causing that irregular cycles.
Let's go back. We have the woman come in. We've worked her up. We've diagnosed PCOS. We now want to do a follow up and talk about, okay, what kinds of things can we do to help, in a way, treat?
Yeah,
because like we said, we can't cure PCOS. It's something that is a lifelong management process.
absolutely.
Let's start with obesity. If this patient does have obesity, what can she do with her weight? What lifestyle things can she do to maybe help improve her PCOS symptoms?
Yeah, this is a really sensitive subject.
Yes.
I don't know a lot of women that are 100% satisfied with where they're at with their weight. And so when we talk about weight and weight loss, first of all, it needs to have an approach of sensitivity,
right.
Because these women have a much harder time losing weight. This isn't just a self-control or a will issue.
Likely she's tried many times to
Absolutely.
lose weight
And
already.
she may have been told by a practitioner, well, work harder, try harder, calorie deficit, et cetera, or tried fad diets or whatnot.
The problem is when you have the insulin resistance, your body doesn't work as well
Absolutely.
as someone who is insulin sensitive.
You are fighting an uphill battle,
right?
For sure. You can eat the same thing as your roommate does. You gain weight, she doesn't.
Right.
Yeah. So, but I mean, research does show a 5 to 10% weight loss can be really, really incredible for symptom management of PCOS. So I think, discussing it, figuring out ways both nutritionally and through exercise that you can support her. And also, first of all, I mean, 5 to 10% is not a huge amount. We're not talking about hundreds of pounds here, typically, right?
So keeping it reasonable.
Absolutely. Yeah.
And giving them, a smaller goal, an attainable goal.
Absolutely.
The nice thing is once she gets there, she's likely going to be feeling
better,
more confident. She's going to have more energy, and the weight loss can continue.
Absolutely.
But to give an attainable goal, 5 to 10%,
right,
is helpful.
Right. Yeah, and then just understanding that these aren't your typical women. These are women that struggle with leptin and ghrelin control, which is that satiety and hunger cues and the insulin resistance and et cetera. So yeah, I think it needs to be discussed and it needs to be a part of the plan. If obesity is a portion or applicable,
for her.
Yeah, for sure.
What type of nutrition goals do you give them?
Yeah, so I really don't have one specific diet plan. I don't really love the term diet as far as go on this extreme diet or that extreme diet. There's no one food that I say, oh, you absolutely have to avoid XYZ food. But I do, if I'm going to focus on anything, the focus would be on maintaining blood sugar levels. Okay. So I like to help patients understand this by explaining what glucose does in their body. I will also often give these patients a glucose monitor so that they can literally see
what the food is doing,
the food that they're eating and what it's doing to their body and how they can respond appropriately. Because as I mentioned, when we consume food, our glucose will rise. Well, when we consume certain foods and in a certain order or without other foods attached to it, our glucose can rise really sharply and then drop really dramatically. And in my PCOS patients, it is dramatized. It is exaggerated. We get these high highs and these low lows. And when we get that low, they're fatigued and they don't feel good and their body naturally gravitates towards something that's going to really boost their energy again, which is typically a
Uh,
carb,
right,
yeah,
right.
something that's going to shoot them up higher again. And so we're just getting all these high highs and low lows. And so typically what I talk to my patients about is helping to maintain kind of foods that have a low glycemic index, or foods that help sustain and maintain blood sugar longer. I mean, ultimately, you're going to feel more
What are those
satisfied.
things?
Yeah. So carbs aren't bad. Okay, we need carbs. We need carbs for hormone production. Often PCOS diets will include low carb or no carb. Research actually shows that low carb is superior to no carb in PCOS patients. So that's, making sure that we're adding protein with a carb. So I will often tell my patients, dress your carb, or no naked carbs. That's kind of my thing. So making sure that if you have a carb, if you're having an apple, pair it with a cheese stick. If you're having a granola bar, put a beef stick with it, or some peanut butter or something like that. Okay, so that so that your glucose rises more gradually
Right.
and sustains for a longer amount of time. I used to be an insulin nurse for years in the school system, and I would have little, type 1 diabetic kiddos coming in with a blood sugar of 60, super low, and immediately I'm breaking out the juice box and I'm getting fruit snacks, but I'm also giving them a scoop of peanut butter, or
Right.
I'm giving them a cheese stick or
Right.
something like that to help sustain their blood sugars. So that's my first thing is low glycemic foods. When you choose carbs that have more of a low glycemic effect. So these are whole grains, quinoa, brown rice, steel cut oats. There's lots of fruits and vegetables that fit into that category. Your dairies are going to be like your Greek yogurts and things like that. So,
but trying to pair it with something that's
absolutely
high in protein
Yep.
or high in fiber,
right.
those things that will kind of help stabilize
Yeah.
that glucose level
Yeah.
and keep them from those big spikes and drops.
Yeah, absolutely.
What about exercise? Exercise, I feel like is something that can be really hard for some women.
Right.
It's a chore. And I do believe that with some education and some additional ideas for them, that they can see it as a tool and actually learn to enjoy it.
Right.
But how do you counsel your patients on exercise in the face of PCOS?
Yeah. So, I mean, it depends on where they're at, right? If they're not exercising, we need to begin something. And I want to start by saying all exercise is good. Whatever way you
Anything.
want to move your body
Yes.
is good. The best exercise is the one that you adhere to.
Right.
It's the one that you enjoy. It's the one that fits into your lifestyle. If I were to pick a type of exercise, I would recommend strength training. And here's why. Because muscle is a glucose sponge. So the more we can build our muscle, the better we can utilize glucose. So it's just an added tool to helping to sensitize insulin to glucose. It's helpful for the more muscle we have, we're burning glucose when we sleep, when we sit, when we throughout our entire day. So, and that can be intimidating for some people. I often will look at women and say, look, you don't need to get a gym membership. You don't need to spend an hour at the gym pumping iron. But start with moving your body. One of my favorite ways to start somebody who's not in an exercise regimen is to start with walking. And I am a big fan of weighted vests.
Yes.
I know they're trendy. I know that all the cool girls are wearing them, but I'm a big fan. I think it's a really great way to move your body and to add resistance training.
Right?
Yeah,
and the
absolutely.
resistance training doesn't have to be, like you said, in a gym surrounded by meatheads. You don't have to be lifting heavy weights. You can start with just body weight.
Yeah.
And do resistance with just your own body weight.
Absolutely. Somebody that works at a job, sitting at a desk for 9 hours, I will often say every hour, stand up and do 10 squats. 10 squats. I do that. You will see me in my office doing 10 squats.
You'll
often.
see me hiding around some corner doing my squats as well. And usually that's either before a meal, it's after a meal, because that is going to help your body use that insulin or use that glucose that you just consumed.
Yeah, absolutely. If we can move our body even just 10 minutes following a meal, so going for an evening walk after dinner, throw a
I shouldn't just
CGM.
go take a nap.
I know. I know, right? Throw a CGM on, that continuous glucose monitor, and you will see what walking after a meal does to your blood sugars. It's really pretty incredible. So, I mean, again, prioritizing weight training, and it doesn't have to be a ton and a big amount of time. I usually will say 20 to 30 minutes, 2 to 3 times a week, to start. And then, but ultimately moving in a way that works best for you. I mean, I do have some girls that are runners, and more power to you. I used to be a runner, and my body doesn't respond super great to running. But if I have patients that are just really, really passionate about running and that's their mode of exercise that they love, we kind of need to talk a little bit further about how you're fueling your body, what you're doing for stress management, because cardio can stress the body further. Right. So if you're already in a stress state, if you're in, if you've got PCOS and it's undermanaged and your body is already feeling very, very stressed by inflammation and things like that, adding cardio and really intense HIIT workouts to your regimen is probably going to
raise your cortisol more.
Absolutely. Put you behind more than ahead. So it kind of depends on the individual person. Right. But running probably isn't my first go-to for exercise for my PCOS patients.
Yeah. I feel like for some women, they run and they are able to lose weight because of, where their stress levels are and cortisol level. And then you have those others who will run 40 miles a week and don't lose any weight.
Absolutely.
And they don't understand why or what's really going on with their body, but it's just that it's a little bit too much stress for them.
Yeah.
And they need to
and when your body's
modality.
In a stress state, it tends to hang on to fat.
Yes.
And it tends to downregulate hormones. That can be another cause for lack of hormones in PCOS is just a stress response that your body is having as well. The point of periods is to procreate. I mean, that's not everybody's goal, but that is the point of having cycles. And so that's the last thing that your body's going to do if it's stressed. It's the first thing it's going to cut out. Well, we can't have a baby right now. We're super stressed. Let's cut that off. So that can also be another factor. We don't talk about stress a whole lot in this podcast, but it's a big factor when it comes to PCOS as well. Learning to manage stress appropriately.
Kind of going back though to the weight loss side. Are there medications that you will use to help your patients lose weight if they are, already exercising and trying to eat healthy? What medications might you introduce then to help them lose weight? Body fat it's very inflammatory.
Absolutely.
And so the more of that you have, the more inflammatory state you're in, and that will make it so that you can't lose weight.
Yeah. For sure. So I do. Yeah, absolutely. There are really great medications and we go all the way from supplements to, trusted medications that have been around for years and years and years to kind of more of the newer treatments. So it's a broad spectrum, and I usually, educate and introduce and meet patients where they are and what they're wanting to try. So supplemental inositol is a really, really, really great supplement for PCOS patients. So all these medications, so I'm going to talk about inositol, metformin, and then the GLP-1s. And they're all insulin sensitizing medications and supplements. And I use them differently depending on where a patient's at. But I really like inositol for probably all of my PCOS patients. That's one thing that I will recommend even if I do it in conjunction with something else.
What does the inositol do for?
So it helps sensitize that insulin to glucose. And it has to be in a very specific combination. So it's myo-inositol and D-chiro-inositol in the 40-to-1 ratio. For some patients, that's a once a day. For some, I'll recommend twice a day. And again, it depends on what other things we add into the mix. But that has been really, really helpful to resensitize insulin, to bring periods back online, to lower androgens. So I use that routinely.
Why might you not use inositol? Is there a side effect or something that you see with inositol that might make you choose to not use it?
Typically, no. I feel like inositol I use definitely in my younger populations. So in my adolescent and my teenage patients, for sure, I feel like those patients
It's a good
respond
choice for
really, really
them.
well. Yeah, for sure. And then there's metformin. And I do like inositol too for patients that don't tolerate the side effects of some of these other medications
Right.
because it doesn't have the same GI side effects that metformin or a GLP-1
Right.
has. So then there's metformin, which has been around for many, many, many years. I usually use the extended release formulation because the GI effects are a little bit better. It's only taken once a day, and it works pretty well too.
That is one that you do have to start low,
Yeah,
because of those GI
yeah,
effects.
yep, for sure.
And there are some patients that even as you start them low and
They
try and
just don't
titrate up,
tolerate it.
that they don't tolerate it, unfortunately, because that can be a really good medication
For sure.
for PCOS to help them utilize their glucose
Absolutely.
and get some weight loss.
Yeah. Yeah. So and then GLP-1s.
Those are amazing drugs.
They are amazing drugs. They really, really are. And they've been around for 30 years. When we talk
Right.
about metformin being around for years and years, GLP-1s have also. We just haven't known all of their incredible uses
Right,
until
right.
now. And so with PCOS, I mean, and these things are just tools, right? All these things we're talking about are tools. They're tools in the toolbox that help with overall underlying condition symptom management. So when I use a GLP for PCOS, it's personalized dosing. The buzzword right now is microdosing. Everyone's talking about microdosing GLPs, and that is what it is. But I use personalized dosing because honestly, it's different for everybody.
Right.
It's different for everybody. I do not have a set protocol that I give to patients that says, this is what you're going to do with your GLP and all of my patients. It is so personalized based on their labs, their symptoms, how they tolerate it, whether or not we need to go up or hold or, what their weight loss is. So it's super personalized, and I give patients my emails and we have conversations on a regular basis about how to utilize these medications.
The other nice thing I think with the GLPs in PCOS is that it does have that anti-inflammatory property to it.
Yep.
And they're in such an inflammatory state.
Yeah. I have so many patients that are like, my hands don't hurt in the morning and my feet don't hurt when I run, and if they're running. When I strength train.
Well, when are you going to, rather than use or maybe after you've already started to use some of these medications you're mentioning, when are you going to use a birth control pill?
Yeah.
Because I feel like in mainstream medicine, birth control pills are the first thing that are given to a lot of these women who complain of irregular menstrual cycles.
Yeah. I'm going to be honest, and I don't treat with birth control very often. I just don't. When I use birth control is when a woman has sperm in her life and she needs to prevent a pregnancy. Right. That's really when I use birth control. Now, don't get me wrong. Some women they want to see those regular periods. They want to have a monthly bleed, and maybe I need to use it for a little while, especially if they're having really uncomfortable periods, heavy periods. But those actually aren't usually a side effect of PCOS. That's more of like an endometriosis.
I feel like a lot of the time the birth control pill, it's just a Band-Aid. It covers things up, but it doesn't address those underlying conditions.
And the thing I don't like about it is, in my opinion, periods are a woman's fifth vital sign. So if we are just covering it up and having you have a period every single month through a synthetic birth control method, I don't know what's helping and what's fixing. Right. I don't know when your period's coming back online because we're having this essentially fake bleed every month. And they stop the pill because they want to get pregnant and they think, my PCOS has been resolved. I can get pregnant now. They stop the pill and we haven't fixed anything. Right. So it's just not my favorite thing. Like I said, if you need to prevent a pregnancy, then we'd certainly have a conversation on how to best do that. But otherwise, if we are working towards period regulation, I will often use bioidentical progesterone cyclically to help regulate cycles. And also PCOS is a progesterone deficiency, so that can be helpful as well.
But birth control pills, they can be useful, like you said, in the setting of maybe if you're having really heavy menstrual cycles, that can help minimize the bleed. It can also be helpful in women who have really painful menstrual cycles.
Sure.
So there are reasons, but not just PCOS and irregular, infrequent menstrual cycles to make them have them. So let's kind of shift gears a little bit and focus on the androgenic symptoms, the acne, the hair growth.
Yeah.
What sorts of things can be done to address those symptoms specifically?
Yeah. So there's a medication called spironolactone that goes in and blocks those receptor sites so that androgens aren't as present on the skin and affecting the hair. Again, those aren't fixing that ovarian function, but it just depends on the patient's needs and their symptoms. So if I have somebody that has, really terrible acne, hair loss, they're just kind of at their wit's end with symptoms, then I use those on occasion as a tool to help minimize symptoms as we're helping to correct those, metabolic conditions that we talked about. I often relate it to using a life preserver while we're teaching the body how to swim. And so I will often use these medications to help with symptomology while we're fixing that underlying cause. And I think it's important to realize too that PCOS isn't the end all be all. I mean, there's other reasons for acne and hair thinning and hair loss. So it's really doing a real comprehensive look at things and, looking at a patient's protein intake, looking for iron deficiencies. Maybe they need to supplement with zinc or vitamin A or something like that to help promote better skin health and hair growth and things like that.
Do you have any medications that you like to use for hair growth? You use minoxidil or?
I do sometimes use minoxidil. Yeah, I do.
Do you like it topically or do you like it oral?
I feel like the adherence is better oral. Most women don't love the topical application. In some of my older patients, I'll use topical just because it's a little bit safer medication for them. But I think most women prefer taking a pill over a topical preparation.
And then, with that hair growth, that, the face, the belly, the back, I like to counsel patients that, the medications like spironolactone, the anti-androgenic medications can be useful to minimize that hair growth, but there does need to be some way for them to get that hair removed. I've talked to some of them about, laser hair removal.
Yeah, absolutely.
Different things to help them, remove that unwanted hair because those medications are not going to remove it for them.
Absolutely.
It will help slow it, but they might still need to do some things to manage the hair.
For sure.
Well, I feel like we're kind of wrapping up a little bit here.
Yeah. It's a big, this is a big elephant to take on, but I think we're doing a pretty good job.
Let's summarize a little bit then. So you have someone walk in diagnosed with PCOS. What are the first steps that you're going to take with her?
In integrative medicine, which I feel like is what we're doing here, right? We're taking the standardized treatment plans, and then I also look at nutraceuticals too. So that needs to be a part of the equation. So depending on what her needs are, again, inositol is a really great supplement. I will break down what does your diet look like, what is your exercise routine. Often I find women are vitamin D deficient, and vitamin D is a really great vitamin. I hate that it's even called a vitamin because it's so much more than that.
Right.
It gets converted into the liver into a steroid. It helps regulate so many other functions of the body. So it really does help with hormone regulation. So often, we add more vitamin D to their routine. Omega-3 fatty acids is another supplement that I will usually make sure that a patient is taking, usually in form of fish oil. We're generally not super great at getting more than 3 servings of good, high quality Atlantic salmon on a regular basis. So fish oil is really great. It's a super great anti-inflammatory. And then usually we'll talk about, other things like magnesium, especially if they're struggling with anxiety, depression, sleep struggles, painful periods. Bringing magnesium in is a good option as well. So those are some of the nutraceuticals that I discuss with patients. And then, we bring in all those other things that we've already talked about, lifestyle and whatnot, just depending on what their needs are.
Are there any additional lifestyle things that you talk about outside of nutrition and exercise? What about stress management?
Yeah, stress management is huge. Jen's talked about this before on the podcast, and I've adopted her 5 pillars of health. We really have to make sure that, and I'll say over and over, you can't out-supplement your lifestyle. You can't
Right.
out-medicate your lifestyle.
Right.
If you don't have good foundations, if you're not sleeping well, if you're not moving your body, if you're not connecting with and having good relationships with people and friends and family, if you're not fueling your body well and moving your body well, we can only do so much on the medication and supplement side.
Right. You know what I love so much too is that in our clinic, you have the ability to spend this time
Yes.
with these women and really get to know what they need so that you can guide them.
Yeah. I mean, we've talked for 45 minutes about PCOS, and a typical appointment that you might have with your provider is 15.
Right. And that's your annual exam.
Yes.
And so you also need to do your pap smear and your breast exam and talk about everything else.
Right.
And it literally leaves 60 seconds to talk about your PCOS symptoms and what you might be able to do to manage them. So I love that you have this time, that you're able to take this time to really do a deep dive with our patients.
Yeah. Yeah. No, it's been a really great transition for me and for the women I'm helping. So,
well, I think that was a really nice discussion. I appreciate all of your knowledge and all of the things you're able to share today. You're amazing. We just want to close up by saying that Taelor and I are practitioners, but we are not your practitioner. There's no doctor-patient relationship that has been established today, and we'll see you later.